Hey friends, it's me. Welcome back to my website. Today we're going to talk about non-destructive ectopic pregnancy management. So that means managing an ectopic pregnancy without hurting the baby. So I'm going to go over the various steps, which include delivery of the baby from the ectopic pregnancy site, such as the fallopian tube, and to wash the baby, then incubate the baby, then encapsulate the baby, then transfer the baby to the maternal uterus, and then redeliver the baby at term. So let's look at what babies look like first. So we're going to use as our example a baby at 6 weeks from conception. So this drawing right here, figure 37, shows the full extent of the baby's body. So all of this is the baby's tissue. Um, Something that's sometimes missed is this TS, the trophoblastic shell, and that's actually connected to these little frondy things, which are the chorionic villi. These are what uh, filter out the needed metabolites, the nutrients and oxygen from the maternal fluid. So what happens is uh, the cells of the trophoblastic shell, the trophoblast, they actually modify the maternal blood vessels, and so there's actually little holes in this outer sphere that are the venous and arterial fluid supplies. So this part inside, in between, which is called the intervillous space, um, so bounded by the trophoblastic shell and this inner membrane here, which is the chorion. The intervillous space forms a hemochorial bladder. So that's just something that sometimes is missed by anatomists, the hemochorial bladder. But when we're delivering the baby, um, trying to find the picture. Here we go. So this is the mother's fallopian tube. Oh, let's look at it right here. So here's the baby inside the fallopian tube, the ectopic pregnancy, and here's a cross-sectional view. And here, right here, where it says UTL, it's the passageway through the fallopian tube, and the baby actually goes through the wall, and and burrows in, and then starts growing. And so then to deliver the baby from the ectopic pregnancy site, you're going to have to do some surgery. So you're going to make a cut in the fallopian tube, and then you're going to enucleate the baby. The baby basically will pop out like an eyeball. And see right here, TS, the trophoblastic shell will typically be adherent to the fallopian tube wall. So you won't have to worry about that. It is important that it no longer be there in place because it will interfere with your ability to circulate fluid over the baby's chorionic villi. So after you deliver the baby, you're going to have to wash the baby. And you're going to wash the baby, in ventilating fluid or ventilating liquid. it's going to change in composition over the sequential stages of the fluidic ventilation. So there's different stages, but right now we're looking at the early stage when the composition is going to be very similar to oxygenated maternal blood plasma, and there's different oxygen tension measurements throughout pregnancy, and so it's age specific. So you're going to wash the baby, and then you're going to get ready to put the baby in an incubator. But before you do that, you have to know about the anatomy, because the ventilating fluid has to impact has to circulate the anterior pole as opposed to the posterior pole. It can do the posterior pole as well, but the anterior pole, also called the umbilical pole, because here the umbilical cord is, that's where the chorionic villi feed directly into the umbilical cord to nurse the baby. So here's the baby part that we recognize. This is the formal body. This part here is all the baby's tissues. So it's also part of the baby's body. In other words, this is what the whole baby's body looks like here in figure 37. But after you deliver the baby, the trophoblastic shell should have been removed. If not, then you're going to have to pick it away surgically to remove it so that the ventilating fluid can circulate between the chorionic villi. So this is the spacesuit or peripheral body, and this is the baby part or formal body. So this is all the baby, but we recognize this figure 2A as being the baby part, whereas this is the baby spacesuit. It's literally a fluidic spacesuit. So it encapsulates the baby. So let's just go through the anatomy real quick here. So we have the chorion, which is this membrane, and then the amnion is another membrane inside. Eventually, these two will fuse. So at this point, let's show where they fused. This is an older baby, and what will happen is that posterior chorionic villi will get scrunched between the trophoblastic shell and the chorion, and then the anterior chorionic villi will form the placental disc. So that's right here, and that's a process that takes place over the course of the baby's growth. So we have the chorion, the amnion. The amniotic fluid is inside the amnion. The chorionic fluid is inside the chorion. There's the umbilical cord. There's the umbilical vesicle. And that's the chorionic villi, very important. So you're not going to want to damage the birth sac in any way, the gestational sac. You're not going to want to damage the chorionic villi, especially at the anterior aspect, at the anterior pole. So you can actually divide these chorionic villi, conceptually into the anterior aspect of the chorionic villi and the posterior aspect. So the anterior aspect is called the alluvia interioris. The posterior is called the aluvia posterioris. You're going to concentrate your efforts on the fluidically ventilating the anterior aspect. So what that means is after you deliver the baby and after you wash the baby, you actually have to transilluminate the baby, like candling an egg to locate the the umbilical cord where it attaches to the chorion, so that you can find the anterior pole, the umbilical pole, and that way you can face that into the direction. If you look at figure 1A, the ventilating fluid is being circulated with emphasis over the anterior pole. So then you can have a incubator, which ranges from here's a very crude example. You have blood plasma with a low oxygen tension at the approximately the same temperature as the maternal uterus would be, and the fluid flows down. Fresh fluid flows into contact with the anterior aspect of the chorionic villi, and then that enables the nutrients to go through the baby's umbilical cord to the baby, and also allows the waste to be removed, and then the fluid flows out the bottom. So that's a simple incubator. There's a more advanced incubator where the baby's fully submerged, and we have this thing right here as a ventilation head. It's basically like a shower head, except it circulates bidirectionally. So it has the arterial ports labeled A, which sends out fresh fluid, in this case oxygenated blood plasma, and then the venous ports withdraw the waste fluid. So it provides that circulation. So here you see that the ventilation head emphasizes the anterior aspect of the chorionic villi, the alluvia anterioris. The remaining fluid is basically just, it's going to be. It doesn't need to be the rich. It doesn't need to have the rich content that the fluid that circulates over the anterior aspect. It can just maintain the osmolarity and so forth to prevent these chorionic villi from dying. Basically, they still need to sustain the chorion itself. After you put the baby in the incubator, so whether it's a crude incubator or a more advanced incubator, then you're going to want to transfer the baby to the maternal uterus. You can do a bare transfer where the baby is just put in without a capsule, but the larger the baby gets, the more you're going to want to use a capsule. You're going to have a capsule, and you close the capsule around the baby, and you're going to put a catheter inside the capsule. So the catheter has little holes up here, and those holes they circulate the ventilating fluid over the anterior aspect of the chorion, so that the baby is properly ventilated during the time inside the capsule. So what happens is you can do it various ways, but the preferred method is transcervically. You're going to dilate the cervix, um, and then you're going to insert the baby in the capsule into the uterus, and the ventilating catheter proceeds outside the uh, the cervical canal. So here you see an exemplary uh, catheter. It has little holes for arterial fluid, for the fresh fluid, and then the holes for the venous fluid, for the waste fluid. So circulating in, circulating out. Um, so what's going to happen is that after a time, the capsule dissolves like a cold capsule, and that leaves the baby there implanted in the uterus. Now we know from the case of the example of a secondary ectopic pregnancy that babies are very capable of reimplanting, reattaching to the uterus. So what happens in a secondary ectopic pregnancy is that the fallopian tube here in figure 3A will burst, and the baby will travel into the mother's abdomen and then attach somewhere, maybe to the outside of the uterus, any place where there's enough blood flow for the baby to be ventilated. And so what happens is that these little chorionic villi, their tips, um, generate trophoblast, and the trophoblastic shell is formed, which modifies the maternal blood vessels so that then there's a circulation of fluid within the hemochorial bladder. So that's in this stage and in this stage. So here we have the chorionic. Here we have the placental disc has been formed. The placental disc is distinguished basically by there's going to be a septum in various places, septa, and these septa they provide chambers so that the fluid circulates, in a way that promotes comprehensive contact with the chorionic villus. So this is a villus tree right here in the center. Um, so after the baby has been planted, you can either withdraw this catheter or basically you can leave it in place. Um, then the baby will grow, and then you'll redeliver the baby at full term. So that basically sums up the non-destructive pregnancy management procedures. If for some reason you're not going to be able to transfer the baby back to the maternal uterus, then you can keep the baby in the incubator, even if it's a crude incubator like this figure 4 for hospice care. And then when you do that, it's important to maintain scientific protocols so that how long did the baby survive, what sort of things did you do, so that whether you're using a crude incubator or a more advanced one, you learn from your experience, and that promotes the general progress of medicine, and will eventually be able to improve the care of future babies who will be able to survive. So We should never, for any reason, commit homicide by, destroying the baby, in an ectopic pregnancy. We should always take care to deliver the baby and provide the baby with the best care, whether it's hospice care or, transferring the baby back to the maternal uterus, for another chance at full-term gestation.